Now the next patient, Dr. Hind, please.
22 years old, women present with right lion vein, liguria and galleria. Blood pressure increase 160/70, and urinary dipstick show protein for cross, and blood for cross microscopy is weighted. Blood test reveal hemoglobin 126 normal, white cell count 8.4 normal, platelet 412 above where high, sodium 137 normal, potassium 5.7 high, creatinine 263 high, urea 5.2 normal. What is the most appropriate next investigation of this patient?
Urea 2, doctors, maybe mistake here. Sorry, I need to correct it.
Urea 2, yes.
5.2. Okay. Somehow 2 is there. So, is the same question as before, doctor?
No,
No,
No.
different is
So what different message you are getting here other than the previous one?
renal sufficiency.
That means the renal dysfunction is there, insufficiency, renal impairment, as well as electrolyte problem. Potassium is high also, right? And the blood pressure, look at the previous one, doctor. Blood pressure is high. There is a proteinuria as well. So is it simply stone disease? What do you think? More likely or less likely?
Less likely.
But we cannot ignore also. So now what investigation we will do now for this such patient? What could it be? What could it be? If we cannot think, what could it be? I cannot plan the investigation.
renal biopsy?
To exclude what?
Exclude glomerulonephritis.
Glomerulonephritis. Why you are thinking glomerulonephritis?
And hematuria, proteinuria, or high
That means
blood
the
pressure.
both are there. Proteinuria and hematuria both. And
High pressure.
patient have oliguria also.
Oliguria.
Blood pressure is high also. And the renal impairment also there. Even the tubular damage also there mainly. If potassium high means more likely there is a tubular damage. So it is not simple only stone disease. Okay. So we will plan for the biopsy. You are right. But before biopsy, what is to be done? One ultrasound should be done. As we have a minimum suspicion of the stone disease also, ultrasound can identify stone disease as well as the renal size and other is very, very important before renal biopsy. Okay, very small kidney renal biopsy could not be done. So for this reason, the most appropriate next investigation will be the renal ultrasound. Okay, technical answer. So this is glomerulonephritis. But if we think, Dr. Shaza possibly telling that as a blood is there, maybe nephrotic issue. Sorry, proteinuria, 4 plus protein. We are not sure because we need to measure 24-hour protein. 24-hour urinary protein, then we can say nephrotic. So if it is a nephrotic protein, then the patient will be of nephritic both. Okay, nephritic and nephrotic. So nephritic syndrome also needs biopsy. Okay, and renal ultrasound scan is the best next investigation. If biopsy needed later, we can see. And now we will be discussing about hematuria, proteinuria a little. So these are the causes of hematuria. To remember, painless and painful. So this, you see, commonly painful hematuria is urinary tract infection, renal stone with obstruction, and the loin pain hematuria syndrome. But painless hematuria is always dangerous. The very dangerous disease is actually painless hematuria. Painless hematuria. Okay. And painful and painless may be in this disease. Even urinary tract infection without pain, in your experience also, you can remember. Adult polycystic kidney disease, there may be pain or may not be pain. And the renal stone, without obstruction, there may not be pain. May be pain or may not be pain. Okay. So painless provided there is no acute obstruction of the urinary tract. That means star-marked tuberculosis, schistosomiasis. These are the painless diseases and there is no acute obstruction. The disease itself does not produce pain, but if there is any obstruction anyhow, then there will be pain. There will be pain. So these are the list, and now the patient to you. Please, anyone who will read it, Dr. Shaza, please. Yeah.
45 years old male presents with long-standing history of hypertension. Investigation show urea 10.2 millimole per liter, creatinine 150 micromole per liter. Which one of the following would suggest diagnosis of acute glomerulonephritis?
So again, we are thinking about glomerulonephritis, hypertension. These are the features of glomerulonephritis. Renal function also in problem. What will be the answer? Quickly, doctor.
24-hour urine protein.
24-hour urinary protein excretion 0.8 gram. It is in feature of glomerulonephritis, or even it can happen in urinary tract infection also. Some protein will be there.
RBC cast.
Why you forgot this? Yeah, RBC cast.
RBC cast. Yeah, you told us.
Just before. So that I discussed before the RBC cast. You see, RBC will come up from the glomerular slit and come down in the tubule, right? Okay. This is the tubule, doctor. You see the tubule cross section. In the tubule, there is a protein. So protein is the mandatory component of the cast. Okay, cast is produced in the tubules, right, doctor? Cast is actually produced in the tubules. Now, RBC is mixed with the cast, it will named as the RBC cast. So from where RBC coming? Usually from the glomeruli, because the RBC will come down to the tube and the tubules provide the protein and mix up to create a cast. So RBC cast in the urinary test, that is a urine analysis, is highly suggestive of glomerular disease.
Hyaline cast from where?
Hyaline from the tubule, doctor. Hyaline is a usually normal, doctor. Hyaline cast. Cast is a common. And why casts are not clinically much significant? When urine become dry and urine is not processed immediately, and the dry urine can produce many casts. So it will give us false result. The hyaline cast and other. But the presence of RBC cast is always significant. So clinically important cast is RBC cast. RBC cast.
Doctor, 24-hour urinary protein can indicate nephrotic?
Exactly. By definition, nephrotic syndrome should have more protein in 24-hour urinary test. 24-hour actually not needed to be that the container will take 24-hour urine. There is a way of calculation. It is called protein creatinine index.
Yeah.
Or albumin creatinine index. We have to utilize it. Or
use now.
I will show you in the glomerular diseases, but there is a calculation you will get in the PDF here. Anyway, the next patient who will read, Dr. Rashid. Dr. Rashid.
A previously healthy 9-year-old girl, present generally unwell, with reduced volume of smoky-colored urine. She had a sore throat 2 weeks previously. On examination, her temperature 37.6 degrees centigrade. She looks quiet and unwell, with slight periorbital edema. Respiratory rate 15, pulse 90. Blood pressure 130/100. Her JBP is elevated and she has tenderness in both loin. Urine deficit show 3+ hematuria and 3+ proteinuria. Red cell cast are seen on urine microscopy.
All the data given. So tell the diagnosis. What actually happening? So there is a features of glomerulonephritis, hematuria, proteinuria, including the red cell cast. Now the
Yes.
background, why patient having this? 2 weeks before, patient have sore throat.
Sure.
Okay. There is one option not given just to make the scenario a little harder. It is called IgA nephropathy. IgA nephropathy also will be like this, but what will be the difference of IgA nephropathy?
Yes.
No, sore throat will be there at the time of hematuria in the same week. Understand? In the
Days.
same week, within days, not week. Suppose patient have the sore throat 5 or 6 days around, patient having the features of the glomerulopathy. It is
So
called,
if it's acute,
is acute, doctor, and it is another name is synpharyngitis. Just to make understand, synpharyngitis. That means that during the pharyngitis, patient have the glomerulonephritis. It is IgA nephropathy, but 2 weeks later, post-streptococcal. That means streptococcal disease is over, then patient developing glomerulonephritis. It is the post-streptococcal. As sore throat commonly due to streptococcal infection, but the broad heading, the terminology will be post-infectious glomerulonephritis, PIGN. The abbreviation will be here PSGN, but the broad heading, general term will be PIGN, post-infectious glomerulonephritis. So already I discussed to you the difference between IgA nephropathy and post-streptococcal. If you look at the picture, you see hematuria, proteinuria there. I will show you in the bigger slide the same. Very, very important slide, this one, for understanding. In the glomerular disease, both hematuria and proteinuria will be there, you see. If you look at the color. But in the kidney diseases, some disease, especially in the left side, you see, minimal change nephropathy, FSGS. FSGS means focal segmental glomerulosclerosis, membranous nephropathy, amyloid. Almost there is no hematuria. Diabetic nephropathy, according to the graph, you see, very less likely have blood, otherwise not at all. But MCGN, this type of having the proteinuria and hematuria both, but more hematuria is post-streptococcal glomerulonephritis, including the IgA nephropathy, you see. And the top one is the SLE. It means SLE can present in the only proteinuria, only hematuria, and the both mixed with. So in the left side, these are termed not as glomerulonephritis. Rather, two word will be nephropathy. You see, all are nephropathy. Can you see the name, doctor, here? Diabetic nephropathy, minimal change nephropathy, membranous nephropathy, but they are not telling nephritis. Now you can identify the features of nephritis is hematuria, high blood pressure. Okay, doctor, I think is useful, this picture? I think so. And this is the histology in the nephritic kidney. And here nephrotic. This is the nephrotic. More protein is coming down. More protein is injury to the podocytes are there. So I hope that we will go through it again of this one. This is that some features of the nephritic and nephrotic syndromes. So nephrotic means the protein. Usually 3.5 gram per 24-hour protein. That is collection or by another way I told you that the protein creatinine index or protein creatinine ratio can give us this result, including hypoalbuminemia, generalized edema, and the hypercholesterolemia also. These are the features of the nephrotic syndrome. Remember, hypoalbuminemia, hypercholesterolemia, and the proteinuria with generalized edema, anasarca. Anasarca is the features of the nephrotic syndrome. But here, oliguria, hypertension, edema, anasarca is there. Not too much severe edema though, but hematuria must, red or brown urine. So hematuria, edema, hypertension, oliguria, these are the features of the nephritic syndrome. Okay. Next one, Dr. Hind, please.
15-year-old patient present to emergency department with the facial and preorbital edema. In examination, he has preorbital and bilateral lower limb beating edema. Blood pressure 125/72. Pulse 72 are regular. He has no significant pipe auscultation of the chest. Investigation: creatinine 110 normal, albumin 24 gram per liter, low,
Low, yeah.
low, yes. Urine protein 3 cross. Which one of the following is the most appropriate initial way to treatment?
So what is the diagnosis, doctor? Is it clear? Protein is more, albumin is low,
Nephrotic.
patient have the edema. More likely this is nephrotic. And
Nephrotic.
what is the age of the patient? 15-year-old patient,
Yes.
child patient. So now how to treat? Do we go for the
Three-
biopsy?
Prednisone.
No, I'm asking that. Should we go for the renal biopsy? They didn't give the option here.
Ultrasound.
Ultrasound, that you will do the test now. The option is not there for ultrasound. Rather, they expecting you will give medicine or you will give observe only without any investigation. That is the expectation, and we are learning by reading the question also that
Initial.
this type of patient does not need further investigation. That means in the young patient, nephrotic syndrome, more likely we will give the treatment by steroid, 60 milligram per day for 6 weeks. Then it will be tapered. So underlying histology, more likely it is minimal change in nephropathy. Remember, doctor, minimal change in nephropathy. The minimal change in nephropathy or minimal change disease does not need biopsy in general practice, and most of the time it is minimal change in nephropathy in the pediatric patient. So start the steroid. If treatment is failed, okay, and recurrence is there, again steroid. But treatment is not working here in the initial time, then we will send for the biopsy. Okay. So for the 6 weeks, we will give high doses steroid.